just want to take a few moments to talk about the 1013 and the 2013. Over my entire period of training, I've always heard, oh, well, you can do this if your client is homicidal or suicidal, or you can do that if they're homicidal or suicidal. You have to report it. You have to do something about it. But no one ever told me exactly what is a 1013 and a 2013. And so I think it's important that we talk about this and really understand what each of these things are and how to utilize them. In my observation, there's a fair amount of misunderstanding about what a 1013 is and what it's authorizing mental health professionals and law enforcement or peace officers to do. So the purpose of this 1013, it's a certificate. And the purpose of this certificate is to authorize transportation to an emergency receiving facility. And this form also includes a report of the peace officer or the other person who's providing the transportation. I think that the language on this form is very important. It speaks to the intent of the form and its appropriate use. Counseling professional ethics require us to consider our client's autonomy. And autonomy is the client's right to choose the direction of their life, the direction of their treatment, and to exercise their free will. And the term autonomy is one of the values that's described in the preamble of the American Counseling Association Code of Ethics. In my understanding, respecting someone's autonomy means trying to advocate for, support, and just really preserve their rights to freedom and independence as much as possible. And we're taking that away with the 1013. And there seems to be this just lack of general knowledge about the rights of those individuals being involuntarily transported to an admitting facility based upon and for the purpose of addressing their mental health systems, including suicidal and homicidal actions or intent. The treatment purpose is for crisis stabilization. And if they continue to exhibit the symptoms that led to the 1013 being completed. So one of the key factors that can go wrong at the outset is whether or not the form is being misused by the clinician, including how to manage the assessment of the person's risk factors. In February of 2013, the licensed professional counselors in the state of Georgia were legally authorized with the ability to complete the Form 1013. And this form is a certificate that authorizes that transportation of a person that appears to be mentally ill, and they require involuntary treatment. So there's a list that I provided here of those who are authorized to complete the 1013. And this is going to include licensed physicians, licensed psychologists, licensed clinical social workers or LCSWs, licensed professional counselors or LPCs, advanced practice registered nurses, APRNs, or clinical nurse specialists in psychiatric mental health, which is a CNS, or physician assistants or PAs. If you are just an addiction counselor and you don't have one of these licenses, or you're not a registered nurse, advanced practicing registered nurse, or a clinical nurse in a mental health setting, or a physician's assistant, and you're not a doctor, then you don't have the right to do a 1013. So you would have to reach out to somebody, and hopefully there is somebody in your facility. And if you're in private practice, you'll have to partner with one of these people or have the client's doctor issue the 1013. You're not going to be able to do it yourself unless you hold one of these licenses. So the 1013 form includes some very clear criteria for its use and execution. The criteria that the quote-unquote mentally ill person needs to meet is going to be A, that they present a substantial risk of imminent harm to themselves or to other people as manifested by recent overt acts or recent expressed threats of violence, which present a probability of physical injury to themselves or to other people, or if they appear to be so unable to care for their own physical health and safety as to create an imminently life-endangering crisis. They need to be unstable for this to go into effect. And these risk factors need to be presented at the time of the evaluation of the individual who appears to be mentally ill. The mental health provider completing the form is required to list their observations, and these observations should justify the completion of the form itself. And there has been some discussion about virtual visits and things of that nature. Honestly, we need to be able to put our eyes on the person and make sure that this is actually what's going on. There's also a section where the clinician selects from a checklist and provides an example. So the checklist says this individual has expressed recent overt acts towards others or committed recent overt acts or threats towards others. They have committed or expressed recent acts or threats of violence to self, or they present an imminently life-endangering crisis to self because they are unable to care for their own health and safety. So then at the bottom of that, you would provide the example of whatever it is that you checked off. So the language on the 1013 form states that the transporting peace officer has a responsibility to make diligent efforts to take the, and it will say above named individual into custody. And they have 72 hours after receiving that certificate. Typically, they're executed quickly due to the imminent risk. The 1013 certificate then expires 7 days after it's executed, and the form is to be provided to the receiving facility, so that needs to go with the peace officer or the person transporting the person. And that transportation can be provided by friends or family if it's deemed to be safe, but that doesn't mean that the peace officer is relieved of their responsibility to provide the transportation if it is requested. And it's important to know that the patient should be reassessed by the admitting facility, and that the form that the physician or the doctor has to complete when they're admitted is called a 1014. It's the physician's certification authorizing transfer to evaluating facility. That's the name of the 1014. It has to be completed within 48 hours of the arrival of that person or the patient to the emergency receiving facility, and they must still meet the imminent risk categories that are described in sections A and B in the discussion that we just had about the 1013. They still have to meet those in order to be admitted into the receiving facility. So when a person is held involuntarily, they are to be informed of their rights to a hearing using the form 1015, which is called the Notice of Admission and Right to Hearing. So this form lets the person or the patient state that they believe that they're being held illegally, and it represents kind of the writ of habeas corpus there. And that's invoking the client's right to be seen by a judge if they believe that their civil rights or their civil liberties are being violated. Often the direct assessment for the 1014 is being completed by someone representing the doctor. Then that information is reviewed with the doctor, and the doctor can then help to make the determination. It just authorizes the patient, to stay at the facility for up to 5 days, not including weekends and holidays. So as counselors, we are to do no harm, and we call that non-malfeasance, doing no harm. The challenge here of involuntarily committing someone for transportation to a receiving facility for treatment is that the process itself involves emotional distress for the client as well as a loss of freedom. And we're also supposed to show beneficence or to do good. And so when we make a decision to complete the 1013 or the 1014, it's supposed to be for the client or the patient or the consumer's greatest good. And for me, that means that I think that this step, completing a 1013, is necessary to save my client's life or to prevent them from harming someone else. And when this privilege is misused, and I believe it is misused, it can be misused for various reasons by different parties for various reasons. So let's look at some of these ways that people can often misuse the 1013 or the 1014. So maybe it's a clinician who's not competent in their assessment of imminent risk, or maybe they just rather complete a 1013 for the primary purpose of limiting their liability rather than for its intended purpose. And this goes back to that liability discussion that we were having in the Tarasoff discussion. A lot of people just don't want that on their plate, and so they refer out or they 1013 the client. It could be misused by a parent who's requesting a 1013 based on the child or the adolescent not following the parent's commands at home. Maybe the child has thrown a plate at the wall, or they've shoved a family member and the parent just wants them gone. So that would be another reason that it could be misused. Another reason is the receiving facility extending the 1014 hold longer than necessary based on the person's admitting symptoms when the patient no longer meets the criteria to be held involuntarily. So those reasons vary, but one of the most common reasons seems to be potentially due to the common practices in the admitting facility to maintain their patient census, or the patient just has good health insurance benefits, or maybe there's just a lack of knowledge by the admitting facility staff about the rights of the patient. So we have to be on the lookout for that kind of thing. And as I just stated, that receiving facility has a responsibility to evaluate the patient and then complete a 1014 for the purpose of extending that hold on the client for the purpose of continued evaluation and stabilization. And if the person or the patient has not voluntarily signed themselves in for treatment, that would be another issue, and that is a 1012 where they voluntarily sign themselves in. So the 1012 is a document or form that transitions the patient to voluntary status. And when a person signs themselves in voluntarily, that status does not expire until they're discharged from treatment. But it is important to kind of note that the doctor or the physician determines when they are eligible for discharge. So when a person chooses to transition to that voluntary status, they should also be informed using the Form 1011, which is the Notice of Voluntary Patient Rights to request the discharge. So in other words, they must be informed about their rights when and if they transition into that voluntary status. And if the person wants to be released from their 1012, which is their voluntary admission status, they can complete a Form 1010, which is a request for discharge. And the doctor then has 72 hours, not including Sundays and holidays, to either discharge the person, or they can file a 1021 requesting a court hearing for continued involuntary treatment before the expiration of the 1014, which is that involuntary 5-day hold for inpatient evaluation. Or they can do this prior to the expiration of the 1010, which was the request for the release, which the doctor then has 72 hours to respond. The 1021 involves a court hearing during which the patient's case is reviewed. They have the right to an attorney during this hearing or any other representative to attend, and they have the right to give testimony in their case. And lastly, I want to talk about the 2013. We talk about the 1013 all the time, but no one ever really talks about the 2013, and there's not much information out there about it. But it's much like the 1013. The 2013 is an involuntary hold of the patient, but the basis of the services is for substance use disorders. And we can use this involuntary hold if the client is a danger to themselves or others due to their substance use. But this hold is much shorter than the 1013, so it may be more difficult to use. They're only going to hold the client for a much shorter time, like maybe 24 to 48 hours, just long enough for them to come off of the substance. If you have any questions or comments, feel free to put them in the comments section below this video in the lesson.